A very good evening to you, ladies and gentlemen. Welcome to the online lecture series organized by Dentistry, which is the academic branch of Government Dental Surgeons Association. So for the year 2024, you all have gathered here to witness the very first lecture. And for this year too, we have lined up a lecture series which is covering a wide range of interesting topics, which we would be informing to you later by the end of this presentation. So today, our lecture is about dental radiographs, X-ray visionaries, crafting your dental expertise in the dental radiographic interpretation. Our resource person for today is Professor Ruwan Jayasinghe. He's very well known in our fraternity. He's a dedicated teacher serving at the Faculty of Dental Sciences, and currently he serves as the chair professor in the Department of Oral Medicine and Periodontology. He's extremely busy, not only with teaching and not only by being a clinician, but also he's a very popular researcher, and he guides many students, the undergraduates, as well as experienced lecturers in the field of doing clinical research. So without further ado, we would like to thank you, sir, for accepting our invitation and making sure that this lecture is prepared aiming at the general dental practitioners. So, sir, I'd like to welcome you, and it's over to you.
Thank you, Kemia. Can you hear me?
Yes, sir.
Right. Thank you, Kemia, for those kind words of introduction and also inviting me to talk on dental radiology. This is not a topic which is very popular, but on the other hand, this is a topic which is fine with almost all the dental disciplines and the specialties. So therefore, without having a good radiology knowledge, practicing any branch of dentistry is going to be a difficult task. Let me share my slides. Okay, can you see my slides?
Yes, sir.
Unfortunately, my camera is not working, so therefore you will not be able to see my beautiful face. So pardon for that. We will go ahead with the presentation.
At least you may share a dental radiograph of your face if you have.
Yes. Even though the Kemia has given a very beautiful and interesting topic, I kept it very simple in the first slide. So what I'm going to discuss here is the principles of radiographic interpretation. Taking a radiograph is one thing. Looking at the radiograph and identify and get the relevant information from the radiograph is a different thing. So it needs careful attention, good knowledge, as well as a lot of practice. In addition to these, you need the patience as well. So if you try to do it in a minute or two, you will not get all the information and it can run into problems. So with that in mind, we will start the presentation on principles of radiographic interpretation. I'm sure some of you may be able to recognize this photograph. This is a very famous photograph from a book called Study of Scarlet. And we have two gentlemen here, and I'm sure all the people who are listening to me knows these two gentlemen. One is Sherlock Holmes, the other one is Dr. Watson. So this is the book, A Study of Scarlet, written by Sir Arthur Conan Doyle. And you may be wondering why I'm putting these two photographs. One, I'm a fan of Sherlock Holmes, so I have read almost all the books, and some of the stories I can tell you by heart. So this is the Sir Arthur Conan Doyle. But the reason for me to include this is not that. It is this. So in this book, the Study of Scarlet, Sherlock Holmes tells his friend and the colleague, Dr. Watson, the secrets or the principles of the detective work. The same principles are applied in dentistry as well, not only in radiology. Any field of dentistry, these simple principles are applied. If you want to be a good clinician, you have to have these three principles with you. Number one is the observation, deduction, and knowledge. Without these three, we cannot go into the next step. Observation. There are things for you to see. Look at the radiograph. There are enough things for you to see. I will show you some examples later on, but unfortunately, we don't see them. I will give you some examples which I have gathered during my career. Some time back when I was a OMF trainee, we had a lady who had ameloblastoma in the right side mandible, and it was a massive ameloblastoma where we have to do a hemimandibulectomy followed by a fibula free flap. This unfortunate lady has undergone a root canal treatment 1.5 years ago, and a dental surgeon has done a very beautiful, fantastic root canal treatment, textbook type of a root canal treatment. And when you look at the radiographs taken 1.5 years ago, there were few pre-op, working length, post-op, few radiographs. And in all these radiographs, in the edge, you can see the ameloblastoma very clearly. At that time, if the dental surgeon has seen this, observed this, and identify what it is, so at least to get some opinion from somebody else's, we could have saved the patient's mandible. So that is why the things are there, but we don't see them. In order to see them, you have to train your eyes. So that is the principle number 1. Number 2, deduction. All the things that we are going to see are not equally important. Whenever we are looking at the radiograph, a radiograph can carry multiple things. Commonly, it will carry normal anatomy and its variation. And then it can have artifacts as well as various technical errors. Only a smaller percentage of the areas will be representing the pathology. So in order to identify the pathology, we have to deduct the normal anatomy, its variations, artifacts, and technical defects. Then only we will be able to come into the conclusion that the patient is having a pathology. Now, in order to do this, in order to detect and identify the pathology, and especially to identify the exact nature of the pathology, the actual diagnosis of the pathology, we have to have the knowledge. Without knowing the radiographic manifestations of common dental diseases, it will be very difficult for us to identify what it is. So therefore, please remember the observation, deduction, and knowledge. These are the principles of dental radiology. The radiographs are very essential, helpful in the diagnosis. Without the radiographs, we cannot think about the clinical dentistry. And we are different from our medical colleagues. The medical colleagues are using the radiograph less extensively, not like us. Sometime back, about a decade ago, a study has been conducted in European Union where they have seen, the audit has been done, and they have seen the amount of radiographs taken by different specialities. 40% of the radiographs, all the radiographs taken in the European Union has been taken by the dental surgeons. So it tells the amount of radiographs that we take. The radiographs are essential for us because, number 1, we are dealing with the heart tissues. Most of our dental pathologies are related to the heart tissues, the tooth, and the tooth supporting substances. Number 2, the area that we are dealing with anatomically, physiologically, and pathologically very complex. Oral and maxillofacial region is the most complex region in the body. So therefore, the clinical diagnosis alone is not an easy job. That is why we need the assistance of radiographs more than anybody else's. The radiographs are taken as part of the complete examination. Remember, radiographs should not be taken and must not be taken prior to a complete history taking and examination. Not each and every patient requires a radiograph. Not each and every disease requires a radiograph. Not each and every situation requires a radiograph. So you have to do a history taking examination, and then only you have to decide whether you are going to go with the radiological examination of it. So the appropriate radiographic interpretation has to be used along with the clinical information and other investigations together. Otherwise, it will be near to impossible to come up with a differential diagnosis. Sometimes the dental surgeons who are working in the periphery sends me the images through the WhatsApp and various other channels and want some information. In simple, they want the diagnosis and the help in the treatment planning. But I will not be able to provide you the diagnosis or the information to your treatment planning unless we know the clinical history. Don't think that an expert can read a radiograph and come up with the information. No, it is always a combination of clinical information with the radiological information that only will be able to come up with the diagnosis. Radiographic investigations are essential and important only when you cannot take the adequate information either by the history or together with the examination and other the simple tests. So if you can identify the disease and if you can come up with the plan with the history and examination, then you don't need a radiograph to start with. The radiographs are useful not only in the diagnosis. It is useful in the screening. And sometimes you take the radiograph for something else, whereas you can identify the other problems in the radiograph. And sometimes these problems may not be related to the dentistry, or even general medical conditions. Few general medical conditions can be recognized, identified using the radiographs. Very good example, a DPT can be used to screen the risk of osteoporosis as well as the cardiovascular risk. And the radiographs will be useful to confirm your provisional diagnosis. A lot of people think that the radiographs are essential for the diagnosis only. No, diagnosis is a major part and major reason for us to take the radiographs, but it is only one reason for us to take the radiographs. They are useful for the treatment planning as well as the review or the follow-ups as well. Now, for example, if the patient comes with a class 1 cavity with the complaint of pain, night pain, and when you look at the tooth, you can see the pulpal exposure and you can identify the root canal orifices. So therefore, you don't need the radiograph to identify this is a pulp exposed tooth, a non-vital tooth. Clinical information is good enough. But if you are thinking of doing a root canal treatment, now you have to assess the root canal anatomy, and we may take the radiograph to assess the root canal anatomy. There, we are taking the radiograph only for the treatment planning purpose and not for the diagnostic purpose. So whenever we are taking the radiograph, our radiographic requirement may cover one or more of the above functions. So the same radiograph will give us the diagnosis, and the same radiograph we will be able to use for treatment planning. The patient comes with a toothache and there is a cavity, but we are not very sure whether it is pulp exposed or not. So we are taking the radiograph for the diagnosis. We want to see whether the patient is having a pulpal exposure, whether the patient is having a periapical lesion. And the same radiograph can be used for the treatment planning as well. And the same radiograph can be used if the patient is having a periapical lesion. Later on, how this periapical lesion is responding to our treatment can be assessed using the same radiograph. But at times, it may be one reason or the two. And when we look at these different functions, we can see all either in one imaging modality, or sometimes we may be needing more than one. For the diagnosis, you may go for IOPA, whereas treatment planning, we may have to go for a DPT. Or sometimes you diagnose with the DPT, and for the treatment planning, we may have to go for advanced imaging modality like CBCT. So whenever we are going to take a radiograph, you have to decide why I need this radiograph. So that is the essential, the fundamental. Why I want it. Do I need this for the diagnosis? Do I need this for the treatment planning? Or whether it is for the review or the follow-ups? And then you have to decide what type of radiograph, what type of modality I am going to use for this particular purpose. And whether it is a single modality or whether it is a multiple modality, whether it is a simple modality or whether it is advanced modality. Once you come up with all these decisions, only you have to go and execute your plan and take the request, the particular type of radiograph for you to do it. Number two, whenever you are requesting a radiograph, make sure you are requesting something that you can interpret with. If you can't do it, either you get the support from someone who can interpret it in the proper way. If not, don't request it. If you request something, you are responsible for that. Later on, you cannot tell, I am not the expert in interpreting the radiograph. Now, for example, the CBCTs. Not each and every person will be able to interpret the CBCT. So if you are not in a position to interpret the CBCT, the best thing you can do, you get the advice from the expert, get the report from us. We will provide you the report, then you know exactly what it is. But most of the situations, even a general practitioner must be able to look at the CBCTs and interpret it. So it will depend on what you can do and what you can't do. And whenever we are looking at the radiograph and when we are trying to interpret the radiograph, there are some essential requirements. Without these requirements, it is not good for us to interpret the radiograph. Number one, optimum viewing conditions. Whenever we are looking at a radiograph, viewing conditions has to be optimum. If you are using the old type film-based radiographs, you have to have an illuminator. And this illuminator must be kept in a dark area, not an area which is full of light. The background color, the background light is having an important effect on the final interpretation. And if you are going to look at the radiograph, the digital radiograph in the computer screen, you have to have a standard computer screen with the minimal light in the background. Number two, you have to have some knowledge. Number one, you have to have understanding about the problems associated with the radiographs. Radiographs are not something that will give you all the information. Radiograph is also called as a shadow graph because what it will give us are the shadows. And these shadows are limited to the grayscale. So when you look at the structure, it's not limited to the grayscale. You will get the multiple colors in the structures. But when we take the radiograph, it is limited to the grayscale, starting from pure black to pure white. This grayscale, starting from pure black to pure white, will contain 256 different colors. It is not just black, white, and gray. There are 256 different colors, but fortunately or unfortunately, we can't identify all these 256 colors. We will be able to identify, I will say, about 15, 16 different colors in our naked eye, not more than that. So therefore, you have to identify these problems that we are coming up with these different shadows. And you have to have a good knowledge on the anatomical structures. What is there? If you look at a radiograph taken in the upper 1-1 region, what are the anatomical structures present in this anatomical region? Because certain anatomical structures can mimic a pathology. You have the incisive foramen in the upper 1-1 region. And if you are not knowledgeable about this incisive foramen, when it appears, especially when the site is a little bit odd, you may think that the patient is having a periapical granuloma or a cyst. So that is why the anatomical knowledge is very essential. Then you have to have some knowledge on the common pathological conditions. If you don't know, then you don't know exactly what it is. And finally, systematic approach. This is essential. Whenever you are looking at the radiograph, you have taken the radiograph because you are suspecting the patient to have a periapical pathology. Don't start looking at the periapical region of the tooth. That is the wrong approach. You have to have a systematic approach. Whenever you have the radiograph, you have to screen the radiograph from top to bottom, side to side. Screen it and then try to identify the areas where there are interesting areas. It may be a pathology or not, but you identify, okay, in this area, there is some change. And then go into those areas and look at these areas carefully one by one. If you look at the interested area, the area that where you have requested the radiograph first, and when you see something, you will forget rest of the things and you may not look at the other pathologies that the patient is having, like the case that I mentioned to you earlier. I can tell you any instances where we have seen similar findings. The patient was very interested in doing the root canal treatment, but unfortunately, he has not used the systematic approach, so therefore missed the ameloblastoma. From the legal point of view, when you take the radiograph, you are responsible for the full radiograph or the full data set. You take the IOP radiograph, you cannot tell, I took the radiograph only to assess the root canal treatment. The rest is not my business. No, you are responsible. If you take the CBCT, you are responsible for the full data set and you must look at the data set. If you can't do it, you need to get the support from somebody else's. Look at this radiograph. I will give you a few seconds for you to have a careful look at this radiograph. And if you look at this radiograph, there are multiple pathologies. Look here. Can you see my drawing?
Yes, sir.
Right, okay. Look here. Now this patient is having a tooth, which is pulp exposed with a periapical pathology. I'm sure everybody will be able to recognize the periapical pathology here, right? But at the same time, you can see there's a radio opacity here. So one, now we have a second pathology as well. Now this radio opacity here tells us this is not something that has happened in the recently. So this is giving us a history. The patient had infection previously and it has got healed. So that is why this opacification is there. And not only that, forget this tooth. If you look very carefully, you can see an endodontically treated tooth and opacity in the maxillary antrum. I don't know how many of you have recognized this. So this, what you see here, is basically a sinus polyp. So unless you look at very carefully the radiograph very carefully, you may miss this. And they are there. How many of you have seen a sinus polyp in a radiograph? It is something very common. There are enough instances where the sinus polyp is there, but unfortunately, most of us have not recognized, identified the sinus polyp in the radiograph simply because we don't look at it. We confine ourselves to the pathology that the area is having. So don't do it. Have a systematic approach. Okay. Now, in order to identify the image better, you have to have a good idea regarding the imaging methods and the shadows that is created by these imaging methods, three-dimensional anatomical structure. And to understand that these three-dimensional anatomical structures will be represented as two-dimensional anatomical structures in the radiograph. So therefore the limitations and the superimpositions that you can get. When you look at the two-dimensional structure, we can see only two dimensions at any given time. If you look at IOP radiograph, we can see the antero-posterior relationship and the superior-inferior relationship, not the buccolingual relationship. So the buccolingual structures will get the superimposed. Whenever there is an issue with the superimposition, when the superimposition is a problem and you cannot interpret the radiograph, you cannot identify the details, the best will be to go for a tomography. Your final image, the radiograph that you are going to get, will be affected by multiple factors. Type of the material that the object is having, thickness and density of the material, intensity of the X-ray beam, sensitivity of the film, and position of the object. Now, all these factors has to be considered by the radiographer when the radiographer is taking the radiograph. So most of the time we get radiograph which is not good in quality, and what we do, we go and blackguard the radiographer. We may not go and do it, but in the clinic we do, and we basically tell these radiographers they cannot take a good radiograph. But is it only their problem? The answer is no. Right? We are partially responsible, and I will show you why I am saying so. In order for them to take a good radiograph, we have to help them. Look at this radiograph. Now this patient is having a calculi. So therefore we have taken the radiograph. And can you identify the calculi? Somewhere here, your calculi is present. Now, this is the same patient, a radiograph taken few minutes after. Same patient, same day, two radiographs, only a few minutes apart. Now, can you see the difference? If you look at the first radiograph, you can identify only one calculi, whereas in radiograph, you can identify three calculi. Okay? Now, what has happened here? Now, when we send the radiograph and ask the patient to take us a lower standard occlusal weave or the oblique occlusal weave, the radiographers will use their common knowledge and take the radiograph because they think, okay, you need the radiation exposure for the bone, because we basically take the radiographs of the bone exposure. But here we are not interested in the bone. We want to see the calculi present in the soft tissue. So if you want to see the soft tissue where the calculi, the calcification is not as good as bone, we need the reduced radiation exposure. So unless you provide that information to the radiographer, they will not be able to take it. So therefore, it is our requirement, our duty to provide the necessary clinical details. If you look at the request forms that the government is having in the ministry, you can see there is a big space for the necessary clinical information. But very rarely only we see the dental surgeons filling that part up. We have done audit some time back. Very, very rarely, only a very small percentage of the people are providing the necessary adequate clinical information for the radiographers to do their job. So therefore, it is our duty to provide the necessary. We don't have to provide all the clinical information, but whatever the information required for the radiographer to take the job. Otherwise, they will not be able to do it. So hereafter, please make sure that you provide. Now, sometimes you ask the bite wing, upper 6-7, lower 6-7. Now, if you look at the radiation exposure for upper 6 and the lower 6 is quite different. Now, when we are taking the bite wing, we have an interest only in one tooth. So whenever the radiographer takes it, they have to send the X-ray beam for that particular tooth. If not, it will not be the best quality radiograph. So therefore, we have to tell them, okay, we are interested at the 6. You take the bite wing of lower 6 and the upper 6, but our interest is with the lower 6. So that information has to be provided. There are multiple limitations of the two-dimensional picture and the superimpositioning. It can cause a problem with the overall shape of the object. What you get in the radiograph is not actually what you have. It is basically the changing from 3-dimensional to 2-dimensional. Number 2, there will be a lot of superimpositioning, which cause problems in the identification and location of the object. Now, this is one good example. This is a house, a simple house. And you look at from the front and you can see a house and a water tank, the house. So when you look at from this view, it looks like the water tank is coming on top of the house. But the same house, when you look at from two different angles, the upper one is the lateral angle. Now you can see there is a room gap in between the water tank and the main block, which you don't see in the previous radiograph. And when you look at from the top, you can see the gap or the wall here is not a straight wall. It's a curved wall. That cannot be seen from the lateral radiograph, lateral view. So likewise, the same thing when you are taking the radiograph from different angles, the things can get changed, which we need to keep in mind when we are interpreting the radiograph. Now, one example, each and every tooth, unless it is pathological, is having a lamina dura and a periodontal ligament space. At times, we take the radiograph and we cannot see the lamina dura or the periodontal ligament space. And sometimes we jump into the conclusion saying that this patient is having ankylosis. No periodontal ligament space. No periodontal ligament space means ankylosis. We jump into the conclusion, but the ankylosis is not something common. It is very rare. Most of the time, this loss of periodontal ligament space is associated with the improper angulation. So these things has to be kept in mind whenever we are interpreting the radiograph. Like Kemia said, you can see my picture at least here. Now you can see this is the very famous Sun Temple in Odisha. That is the state in East India, the very famous temple. And you can see here me touching the top of the temple. Is it because I went to this temple and get some additional powers and become a giant? No. Now, this is same me. I was not a giant. You can see here, it is because of the angulation that we have used to take the photograph. So when my friend took this photograph, he was basically sleeping on the floor and took the radiograph in upward angulation, whereas the other photograph is in the same angulation. So that is the same principles will be applied in the radiographs as well. When we are interpreting the radiograph, as I told you earlier, weave the image under the optimum condition, interpret only the good quality radiograph. Never, ever interpret a poor quality radiograph. If you are not satisfied with the quality of the radiograph, throw it out. Whenever we are interpreting the radiograph, that is the first thing that we have to look with, whether this radiograph is in diagnostic quality. If it is not, throw it out. And if you use an improper radiograph, poor quality radiograph, later on you cannot tell, I did this mistake because my radiograph was poor in quality. Whenever you are interpreting the radiograph, the basic assumption, you are happy with the quality of the radiograph. And if required, go for additional waves. Don't depend on single wave. If you can't identify the details with the single wave, request the additional wave or, when necessary, special imaging modalities. Describe your radiological findings. Explain the significance of this finding, why this is there, and come up with the differential diagnosis and find your diagnostic impression. Then only you can go with. The same principles applies for the caries, periodontal disease, or any other major pathology. Basic things will not depend from one to the other. All these principles will be applicable for everything. Quality of the image. I told you the first thing that we are going to look at is whether the radiograph is good in quality. If the radiograph is good in quality, the contrast and the density has to be appropriate. The region of the interest has to be clearly visible with the surrounding normal area. And there cannot be any geometric distortion. So if you see one of the four, reject the radiograph. Don't try to interpret the radiograph. Decide whether you need more radiographs. And if you need more radiograph, if it is not providing you the adequate radiograph, decide which one I want, whether it will be periapical, bite-wing, occlusal, panoramic, whatever the type. And when you are deciding, you have to decide many things. If you are suspecting caries or the periodontal disease, there's no point in taking a DPT or OP, the CBCT. They are not diagnostic radiographs or the imaging modalities for caries, periodontal disease. They are only screening tools. So if you want to look at the caries, periodontal disease, or the sequelae of pulpitis, take either a periapical or the occlusal, depending on your case. But if you are suspecting a larger lesion, then you can go for. So you have to identify whether it is the direct acting radiograph or not. Number two, the area that you can cover with the radiograph and the dimensions that you can see with the radiograph. IOP, I told you, you can see the superior, inferior, and the anteroposterior dimensions. And when you look at the occlusal is showing us the buccolingual dimension. It is not showing us the superior, inferior dimension. In addition, instead of that, it gives the buccolingual dimension. So if you want to see a buccolingual expansion, there is no point in taking a periapical or a panoramic. So likewise, you have to assess it and decide which we need. Number two, do I need the prior radiographs? If the patient is having the prior radiographs, use them. And times you need them for the comparison. Whatever the patient is having right now, whether this lesion is there previously or whether it's a new development, without having the prior radiographs, it will be not possible for you to come up with the information accurately at times. And thirdly, what is the expected diagnostic yield from the radiographs? What information, what is the amount of information that you can acquire from the radiograph? Because at times, you will be able to diagnose it with the radiographs only. Plus the clinical information, it is essential. Clinical information plus radiographs, that is good enough. But at times, it is not. You may need the histopathology as well. Now, for example, if the patient is having caries, the radiograph is good enough for you to diagnose. But if the patient is having something like a cyst or ameloblastoma, then The radiographs alone is not good enough. You have to have the histopathology to go with. So we have to identify the diagnostic ill prior to anything else. Use a systematic process. Whenever we are looking at the radiograph, you have to use a systematic process. Start with the known anatomical landmarks. Right? Now, for example, you have a TMJ weave, and now you have to identify the temporomandibular joint. I will tell you, unless you take the TMJ weave using the DPT machine, the standard TMJ weave identifying the temporomandibular joint is a nightmare. It's a difficult task. So never try to look at the joint to start with. We have a very clearly visible anatomical structure, that is the external auditory meatus. Very visible. You identify the external auditory meatus, and your temporomandibular joint is about 5 to 10 millimeters in front of the external auditory meatus. And then identification is very easy. You are going to trace a canal. Now, we'll say you have taken the DPT. Now you want to assess the relationship of the inferior alveolar canal and the impacted third molar. And when you're looking at the radiograph, the inferior alveolar canal closer to the impacted lower third molar, at times you will not see the superior border very clearly, and you don't know which one is which. So therefore, the best way to start with the mandibular foramen or the ventral foramen, and then trace the canal backwards or forwards. And radiograph, whenever you are looking at, don't start from one point. You start from either from the top to bottom or from side to side. Identify the normal anatomy and then check for the symmetry. Go ahead and look at the bone. Look at the trabeculae pattern. And you have to do this for all 4 quadrants separately. At times, you will see various problems associated with the trabeculae pattern, and some of these changes can be localized, or some of the changes can be generalized. You will be able to diagnose even a systemic diseases by looking at the radiograph if you look them very carefully. Trabeculae pattern, see whether they are normal, whether they are symmetrical, whether they are sparse, dense, or are they in the direction of the anatomical stress, as well as whether the trabeculae pattern is altered. Now look at this radiograph. This radiograph, when you look at it, you can identify all the teeth. There is a bone loss, and the central incisor is missing. At the same time, when you look at the radiograph, you can see the trabeculae pattern is changed and lamina dura is missing. Now the question is whether this is periodontal disease or whether this is something else. So that is the question that we have to ask. The patient is having a missing tooth, and even the other teeth, you can see the alveolar bone is reduced. The alveolar bone levels are very much reduced. But at the same time, you see a significant widening of the periodontal ligament space and complete loss of lamina dura, which is not very much the feature that you get in the periodontal disease. Actually, this patient was diagnosed to have vitamin D deficiency. And the next radiograph. Look at the implant that is there. Now, if you look at the implant very carefully, take a few seconds and look at the implant very carefully. Can you see in the borders a black area? And when you see it, it looks like the implant has not fused with the bone properly. The osseointegration has not taken properly. That is why you see this radiolucency surrounding it. If it is a fully osseointegrated one, you will not see that. Now the question is, we have to assess this to identify whether there is osseointegration or not. This, what you see here, is not a failure of osseointegration. This is what we call as edge enhancement. Now this is a problem that we may get. I am sure all of you know what the cervical burnout is. Cervical burnout, the tooth is normal, but you see a relative radiolucency in the neck of the tooth. That is because you have two highly dense structures in the top and the bottom, but the neck is only the dentine. Whereas the above the neck, we have the crown covered, the dentine is covered with the enamel. Below, we have the dentine covered with the alveolar bone. So that causes relative radiolucency, and here it is the same. Because of the high density of the implant, the surrounding area will get a relative radiolucency. The question is, now how can we differentiate? The easiest way to do it, you get a piece of cardboard, a black paper will do, and cover the implant. And when you cover the implant and this edge, the radiolucency will disappear. And if it is not disappearing when you cover this, the implant, then it is actually a failure of osseointegration, not the edge enhancement effect. Look at the interdental bone, height of the interdental bone, and if it is bite wing, look at the projection, and the bone, look at the cortication, the bone heights, shape of the bony crest. All these are essential to decide whether the patient is having bone resorption, new bone development, or it is the standard or the normal bone resorption you get over a period of time. Look at the teeth, count, look at the enamel, dentine, pulp, count the roots, compare the anatomy. You are looking at the first molar, compare it with the second molar, compare it with the opposite molar, check for the restorations, and see whether there is a pathology related to any of these things. When you look at this radiograph, you can identify in both radiographs, you can see an abnormality, developmental defect associated with the tooth. The upper radiograph, you can see the two teeth are combined, but the crowns are separated, only combined from the root, whereas in the second radiograph, the two teeth are completely combined. So you have the gemination and fusion in these two radiographs. I told you at the beginning, we have to describe the radiograph. This description of the radiograph is very important because it gives us some indication of the tissue of origin, biological behavior of the tumor, whether it is slow growing, whether it is rapidly growing, whether it is a malignancy, a benign, whatever. Then the prognosis, what will happen if we treat or if we not treat. Then the treatment concerns, whether this is a suitable case for a treatment or not. Then it will help us to come up with the differential diagnosis. So how are we going to do this? I will tell you important points only because these points are very critical, especially when you are dealing with the larger radiographs more than IOP radiographs. There are a few points for you to consider when you are looking at the radiograph, and each and every point is carrying some weight. Location and extent, whether the lesion is osteoblastic or osteolytic, or in simple terms, whether the lesion is radio-opaque or the radiolucent, characteristics of the internal lesion, margins, supporting structures, relationship to the tooth, cortical changes, and the periosteal reactions. So these are the things that we are going to look at whenever we are interpreting extraoral radiograph. Location. Location is the exact place. Extent is the size and the spread of the lesion. This has to be identified. Now look at this lesion. So when you look at this radiograph, you can identify a radiolucency in the right side mandible. So I have enlarged it for you to see, and you can identify a radiolucency in the mandible. Now, the diagnosis of this lesion will depend on the location. And when we look at it, we can see the inferior alveolar canal. And inferior alveolar canal, the lesion is below the inferior alveolar canal. So if you see a lesion below the inferior alveolar canal, very simple, it cannot be something coming with the odontogenic origin. So it is nothing to do with the tooth or the tooth supporting structures whatsoever. So here, the most likely diagnosis will be the Stephan's idiopathic bone cavity. I will give you 30 seconds to see this radiograph properly. And if the KME allows, I will allow one of you to give me the answer. In addition to this, because we said you have to screen the radiograph. In addition to this, Stephan's cavity, what else you can see this in radiograph? Kemia, can we allow someone to answer the question?
Yes, sir. I'll make the I'll make sure they are unmuted, sir.
They can raise their hand, or even they can put it into the chat box.
Yes. Now they can even unmute, sir.
Okay, good. Or otherwise, I can look at the participants and ask it from someone.
Randomly.
If there are no volunteers. Just to see whether the people has followed what I'm saying. If not, you can be the volunteer, Kemia. You can tell me what you can say.
Hello, sir.
Yep.
Sir, there are some radio opacities in the left side ramus of the mandible. Multiple opacities.
Excellent. Right, that is what I want. Okay, good. And if you look at very carefully, it is not just on the left side. Can you see them on the right side?
Yes, sir. Right side also there are opacities.
Now, what can they be?
It could be arising from the parotid gland, I think.
Right side? So it is bilateral? Okay, you have given the answer that I want. Now, if you look at this radiograph, it shows you. Yes, please.
The cervical spines.
Okay. Cervical spines. Right, anything else? My interest was this. There are a few others. I will forget about this for the time being because time is a factor. But if you look at this, the region that he has described in the left side, so you can see multiple calcifications. This may be coming from the parotid gland. Most likely, these are the calcifications in the tonsillar area. Even the phleboliths are a possibility. Very much likely a tonsillar calcification than the parotid calcifications because you see multiple of those. And when you look at it in the right side, can you see these calcifications? And even here, when I have enlarged the area, you can see those. And these are not the calcification, the same calcifications. These are actually the same. This is what we call as the ghost images. I'm sure all of you have learned about the ghost image. When the patient is having an earring, it will get the ghost image in the opposite side. This is exactly the same thing. This calcification has given rise to the ghost images in the opposite side. So that is why these are having a very nice clear margins, whereas these are not. Again, the anatomical location. Now you can see here radiolucency in the middle of the two teeth. Now this is not a cyst. This is the incisive canal. At times, depending on the angulation of your radiograph, this incisive canal can be a little high up, in between, or even it can move a little bit towards one side and it may mimic a periapical granuloma. So we have to be a little careful when we are interpreting the radiographs. And when we are assessing the location, you can use the areas to describe where the lesion is. I'm not going to go into the details of these because these are the things that all of you know. To tell exactly where the lesion is, maxillar, mandibular, unilateral, bilateral, ramus, whatever, we use a proper terminology to describe the lesion. The second one, whether the lesion is osteoblastic or osteoclastic. This is what is going to happen. And you can have the extreme ends, 100% osteoblastic or 100% osteolytic. If it is 100% osteolytic, you will get a pure radiolucency. If it is 100% osteoblastic, you will get the pure radiopacity. But you can have anything in between. Sometimes what happens, you get osteolytic lesion, and within the osteolytic lesions, you can get the calcifications. Or you can have osteoblastic lesion, and within the osteoblastic lesion, you can get osteolytic areas. So you can have a combination of the two, and depending on the amount of osteoblastic versus osteolytic, you have to identify what type of a lesion is that. And now, for example, if the patient is having something like a CEOT, calcifying epithelial odontogenic tumor, the patient will have more osteolytic areas with few calcifications. Whereas if the patient is having something like osteomyelitis, it will be more osteoblastic with few lytic areas. So likewise, the percentage of osteoblastic areas versus osteolytic areas will help us in identifying what type of a lesion is. It is in addition to the 100% osteolytic versus 100% osteoblastic lesions. Now this radiograph, you can see a tooth, and at the same time, you can see a lesion in the periapical region. Now you can see the lesion is osteoblastic, a bone formation. Now, what can this be? So this is what we have to identify and understand, because this type of a lesion can occur due to multiple reasons. Now, if you look at in this case, there are a few possibilities. One is the dense bone islet, right? Or what we call as idiopathic osteosclerosis. Or this may be condensing osteitis. Or this may be some other pathology. And when we look at the lesion very carefully, you can see the lamina dura is independent, and you can identify the lamina dura very carefully. So if the lamina dura is identified very carefully, and we can reasonably conclude that this is not something coming from the periapical tissues. So it has to be something coming from the bone itself. So therefore, condensing osteitis is unlikely, because the condensing osteitis is basically coming from the lamina dura. It is associated with the periapical tissues. So the most likely diagnosis will be the dense bone island or the idiopathic osteosclerosis. So here you can see a lesion, a radiolucent lesion in the left side mandible. And when we are describing this, we have to describe many things. So where the lesion is, you have to use anatomical landmarks to describe this. Now this lesion is starting from the mesial aspect of the first molar, and it goes to the lower border of the mandible, and you can see the lower border of the mandible is preserved, and it is not involved in the lower border of the mandible, which is important finding. And then it goes into the ramus of the mandible, and then comes back into the alveolar process as well. Here it is in the alveolar process. So all these informations are required when we are planning our treatment. This is a mixed lesion. The patient is having, I'm sorry for the quality of the radiograph. So this patient is having something like a fibrous dysplasia. This is adenomatoid odontogenic tumor. You can see the calcification, the fake calcifications here and there. This is fully osteoblastic lesion. The patient is having in this case, the patient is having odontome, whereas in the other case, the patient is having a fibrosseous lesion, focal cementosseous dysplasia. And you can see here radiolucency. And this radiolucency, when you look at it, it is not uniform in density. So the radiolucency in the center is much higher. It is much darker compared to the other. So this is what I said regarding the radiolucency. Now, even the radiolucency, there's no necessity for that to be the same all the places. Now, why we have these different radiodensities? Because the thickness of the lesion is not equal. If the lesion is having a very nice roundish shape, it will have a uniform radiolucency. Now, if the lesion is having irregular shape, then the radiolucency will be different, because in the center, the diameter is higher than in the periphery. So this is what has happened here. So when we are interpreting the radiograph, you can have two situations where there is a radiolucent lesion with the radiopacities developing on top of it, or it may be this irregularity. This type of appearance can appear when the lesion is healing. So the patient had a lesion, it has been treated, now it is healing. And when the healing takes place, it is not going to happen in the equal fashion in all places. Then the characteristics of the lesional tissue. So you have to describe it using the overall pattern. This lesion. So you can clearly identify this lesion to be a multilocular radiolucency. So if you look at the posterior lesion and the anterior lesion, they are independent. Sometimes the people get confused regarding the multilocular and the single locular lesions. If the lesion is multilocule, you have to have multiple locules. One locule is independent from the other. At times, you can have a pseudolocule appearance, scallopy appearance. Scallopy appearance does not necessarily mean it is multilocular. Multilocular means you have to have separate locules. And these multiple locules, we give different names depending on the size of the locule. We give it soap bubble appearance, then the honeycomb appearance. All these are the terms that we have to describe. So if you can identify this is multilocular and the locules are larger, that will be good enough. In the upper radiograph, you can see a unilocular radiolucency in association with the lower canine. And in the lower radiograph, you can identify again the multilocular lesion. And you can see this multilocular lesion is extending into the oral cavity. Even the superior margin is extended and you can identify the superior margin clearly. Then we look at the internal margins. So the internal margin is the margin which separates the lesional tissue from the normal bone. And there can be many things happening in this margin. Number one, the margin can become regular. If the lesion is expanding slowly, regularly, the margin will become regular. But when the lesional growth is irregular, happens at a different speed, then your margin will be irregular. In the other words, if you see an irregular lesion, if the margins are irregular, that means the lesion is either malignant or having an infection. These are the two reasons for one to have it. Then you can have regular lesions. The margins, when the margins is regular, that means the lesion is slow growing. Thirdly, you will have a regular lesion with a sclerotic bone surrounding the margin. So if the lesion is having a sclerotic rim or radiopaque area surrounding the normal bone, that means the lesion is very slow growing. There is ample time for the normal bone to produce a defensive barrier. So this sclerotic rim is the defensive barrier. Simple words, we have three types of lesion: irregular margins, regular margins without cortications, regular margins with cortications. Regular margins with cortication is the best lesion where the lesional growth is slowest. Now, the IOPA radiograph, you can see a regular margin, lesion with a regular margin, but there's no cortication. And if you look at this lesion, it is having a regular margins. Then we have to look at the supporting structures of the tooth. So that is basically the periodontal membrane space and the lamina dura. So the periodontal ligament space is the one that we are going to look at it and see whether this periodontal ligament space, the lamina dura and the surrounding alveolar bone, whether there are changes associated with those. In this case, we are not looking at the tooth. The tooth we will look at separately. So here what we are going to look at the surrounding tissues of the tooth. Sometimes because of the lesion, your periodontal ligament space can get widened or the periodontal ligament space can get obliterated. Now, if you look at here, there's a lesion and there's no periodontal ligament space visible surrounding the tooth. In addition to that, you can see the tooth is got resorbed. That's a different story. We will come to that later. But the periodontal ligament space has gone. Sometimes you can get changes with the periodontal ligament space intact. Then we look at the relationship with the tooth. And there are multiple relationships. The lesion and the tooth relationship can be with the crown, with the apex, or with the overall tooth. So when you compare the overall tooth, the relationship can be, there can be impaction, displacement of the tooth, or there can be a floating. Now here you can see in both these situations, the tooth has got displaced and tooth has got displaced in two different directions. So the direction that the tooth is going to displace tells us the area that the lesion is spreading. Now, if you look at the upper radiograph, the tooth is displaced towards the midline. So that means the lesion is growing anteriorly, from posterior to anterior. Whereas in the other lesion, it has grown upwards. So in addition to the anterior growth, the patient is having upward growth as well. Same thing. Then we can look at the cortical changes. The cortical changes are very important, and there can be different types of cortical changes. So these are the cortical changes that we can see. The cortical changes cannot be assessed very well with the IOP radiographs, and you have to combine IOP or the DPT with the occlusal radiographs. Because when we are assessing the cortex, we have to assess the buccolingual cortex as well, the buccal cortical plate as well as the lingual cortical plate as well, in addition to the lower border of the mandible. More importantly, the buccal and the cortical plates. So therefore, it is important for us to have occlusal radiographs. And the cortex can be expanded with visible margins. It can be expanded with invisible margins. There can be endoschial scalloping, cortical destruction, and saucerization. If you see a saucerization, that means the tiny resorption from the periphery. So it is like a saucer, not a big shallow hollow, but a very tiny resorption. That means the lesion is not within the bone, it is outside. So there's a space occupying lesion in the soft tissues which pressurize the bone. Very good example is nasolabial cyst. Nasolabial cyst is primarily a soft tissue cyst. And when this soft tissue cyst enlarges, it compresses the maxillary bone. So therefore, the maxillary bone, because of the pressure coming from the lesion, can get some resorption. That is what we called as the saucerization. The other four are basically the changes that you get in the lesions within the bone itself. Now here you can see a cortical expansion with very clearly visible margin. So at the initial stage, when this cortical expansion takes place, you get the expansion of the cortical plate, and the cortical plate will maintain its normal thickness. And with the expansion, why the expansion is taking place? In one side, you get the bone resorption, and from the other side, the bone is getting deposited. When the speed of the bone resorption is more than the bone deposition, the cortical plate thickness is going to become less and less and less. Now here you can see it's only a very tiny plate. And if we allow this lesion to continue to grow, with no time, this cortical plate will disappear and only the periosteum will remain. And then the periosteum also will get perforated and the lesion will go into the soft tissue. Then we cause a cortical perforation. Identification of this will tell us, one, the growth rate, the speed of the growth. If the lesion is growing rapidly, the cortical expansion will be minimal and the lesion will come into the soft tissues with no time. But if it is a very slow growing lesion, the lesion can expand into a larger extent because we have time for the new bone to form. And if the cortical perforation is there, it means the lesion is aggressive and it grows quickly unless it is a very big lesion. And cortical perforation is critical in identifying a fibrosous lesion. The moment you see a cortical perforation, then that lesion is a lesion which can have a bony as well as soft tissue components. All our cysts as well as the tumors can work in both these components, the hard tissues and the soft tissues. But fibrosous lesions are essentially bone lesions. So under no circumstances, fibrosous lesions will cause bony perforation. It can cause the cortical expansion. The cortical plate can become thinner, but it will never cause the cortical perforation. The moment you see a cortical perforation, we know it cannot be a case of fibrosous lesion. Then the periosteal reactions. Periosteal reactions are not something very common, but time to time you will be able to see them. Now, for example, this case. Periosteal reactions, you may not see them immediately surrounding the lesion, but in a different place. Now this patient is having impacted lower third molar, and association with the impacted lower third molar, we have a paradental cyst. Paradental cyst is inflammatory cyst, and there will be inflammatory fluid formation, and that fluid tracks down towards the lower border of the mandible. And because of the fluid, the periosteum in the lower border of the mandible got extended, and that extended lower border forms new bone. So you will see a different layer of the new bone there. So even if you don't see the lesion, when we see this layer, we know there is some type of an inflammatory reaction going on somewhere. This is very common with the osteomyelitis, because of Gary's osteomyelitis. Not only that, inflammatory conditions which can induce fluid formation can give rise to this. And not only that, you can get the same associated with bony malignancies. Now, this is a case of osteosarcoma, where you can see the characteristic, the sun ray appearance. Again, we are coming back to the, now we are coming to the end of the presentation, and we are coming into the Sherlock Holmes again. So the Sherlock Holmes said us, when you have eliminated the impossible, whatever remains, however improbable, must be the truth. So basically, our diagnosis of radiological lesions are by elimination. You have to eliminate the others, normal anatomical structures, the artifacts, technical errors, all that has to be eliminated. Once it is eliminated, whatever remaining must be the truth. Right. Look at this case, interesting case. And you can see multiple pathologies. The most important pathology is this. I'm sure this radiograph is clearer than the previous, and I will enlarge it and show you. Now, if you look at here, you can identify the inferior alveolar canal and multiple branches of this is the mental foramen, and it continues as the incisive canal, and you can see multiple nutrient canals. Right? It branch upwards nutrient canals. So even the inferior canal can have multiple variations. I have seen enough number of bifid canals. We have published few bifid canals, sometimes trifid canals, and it can have different anatomical patterns. Only thing, we don't see them. Not that they are not there. We don't look at them, we don't identify them. That is our problem. Again, something similar which I showed you earlier, the patient is having bilateral polyps, antral polyps. On both maxillary antrum, the polyps are there. Thank you very much. I have taken a little bit more time than the time allocated to me. If there's any question, I am happy to answer.
Yes, sir. Thank you very much, sir. So you may either type in your question or you may unmute yourself and ask the question. So we'll have maybe 5 to 10 minutes opening the floor for questions. So within a very short period of time, you were able to cover a wide range of information. I think we are very much grateful for that. I just wanted to ask from you, sir. Now, currently among the general dental practitioners, there's this portable radiograph, the X-ray machine, which is quite popular, which I like installed in dental clinics. So just want to know about the sort of precautions that needs to be taken when taking radiographs.
From the radiologist point of view, mobile X-ray units, the portable X-ray units are not recommended. And it is not legal to practice as well.
Right.
Portable X-ray units are only for a specific reason. And it is not because of anything, because of the radiation protection. And you are putting yourself into unwanted, unnecessary risk by taking a portable X-ray machine. So my advice, don't do it. Chapter closed.
Yes, sir. And
because it is not recommended.
right, sir. And it's quite popular in the market also. Like there's a lot of advertising also being done. Yes,
True,
sir.
true, true. I'm answering as a specialist. So
Yes.
this is the specialist opinion. It is in the market and the people are taking. I don't have any problem with that, but the recommendations are different. Whether the people are following the recommendation or not is a different story. But the recommendation, international recommendation as well, it's not my. The international recommendation is not to use portable X-ray units in the dental clinics. The portable X-ray units are for a specific purpose and it has to be minimized. Because the basic principle is the radiation protection. We have to look after the radiation protection. That is why the portable X-ray machines are not recommended in the dental clinic.
Right, sir. So now the digital radiography is also quite popular even in our faculty. So we use digital radiographs. So now when using the digital radiographs and also when you go to interpretation of those, I mean, do you find a lot of advantages rather than using the film-based ones?
Yes, film-based ones are out. Whether we like it or not, we cannot continue with the film-based machines simply because we can't get the chemicals now. And they are damn expensive, as well as it's not freely available. The places where they use the film-based radiography, they are using with the X stocks. Once these stocks are over, we will not be able to use them at all. So therefore, now I will give one example. One of our X-ray developers, this is some time back, spacked up. And we want to repair and we couldn't get the parts. Not only from the country, even from outside, because no place they will produce the developing machines now, other than in China. Still they do it, but no other place they produce, because now the era is over. It is like our cameras. Now, when we were students, we had these cameras where we had to put a film roll in. Now you can get those cameras only in a museum. Now everybody is using the digital camera because it is easier and it is very convenient. The radiography is the same. The digital radiography is having 1001 advantages over the conventional radiographs. So therefore, whether we like it or not, we have to go with it. And initially, you will find it little difficult to interpret the radiograph, and you will find it little difficult to work with the screens and all that. But once you get used to it, it's very, very easy. My advice, if you are going to go for a digital radiography, don't go for a print. The moment you print it, you basically kill the radiograph. You are losing all the added advantages you can get with the digital radiograph. There are multiple advantages. When you have the digital radiography, when you look at it in the screen through the software, you can enlarge it. You can adjust the contrast, which is very essential. You can put the labels and so many things. You can do the measurements, everything. When you print it, none of those things are possible. So try to minimize the print. One thing, the printing is very costly. And the other advantages of the digital radiograph will not be there if you print it. Try to use, and especially the young generation, they are very good with the computers and this. And nowadays it is not difficult. We all are having the mobile phones, the smartphones, and very easily we can see the radiograph using the smartphone.
Yes, sir. Dr. Murang also has typed the same questions regarding the
Yeah. I just check it.
Right.
Sir, excuse me, sir.
Yeah.
Sir, what did you mean by covering the implant with a piece of cardboard in order to rule out?
Yeah, so it's little difficult to tell it rather than showing it to what you can do. I don't know whether you can follow me. No, no. What you can do, you get a piece of cardboard and cut it into the shape of the implant and keep it over the implant. Right? So basically, you are masking the implant. And when you mask it, because this, what we get is the relative radiolucency. There's no radiolucency as such. We see it as a radiolucency because of the contrast that we see from the implant. So what we are going to do, we mask, we cover the implant. And when we do that, that contrasting is not coming into eyes, that radiolucency disappears.
Yes, sir. Thank you, sir.
So thank you very much, sir, for accepting our invitation and doing this wonderful lecture. Even at the last minute, you had a technical difficulty, but you came all the way from your home to the faculty and somehow made sure that you were available on time. So we have so much regard for your dedication. And once again, I'd like to thank you on behalf of all the dental surgeons who have joined today and on behalf of dentistry. So
thank you. Pleasure to be any assistance.
thank you very much, sir. And we would be needing your help because our membership had like previously requested for you to do a lecture, maybe a hands-on workshop on CBCT. So I'll be coordinating with you and making sure that that will be possible. At least an online lecture if we are not able to have a hands-on workshop.
Definitely, we can do it hands-on workshop. We will be able to work out something and to do the screen sharing and do it, which I have not done, but we can give it a try and see how we can do it. Lecture definitely not an issue, but when it comes to the cone beam, more than the lecture, what we need is the hands-on session. We will sit together and work it out. I'm sure we will be able to do it online. If not, we'll see whether we can do it in few places.
Sure, sir. Dr. Dilhan has unmuted his microphone. I'm not sure whether he's going to ask a question. Right. So there are a few announcements to be done because February, the month would be quite busy for... Yes, sir.
Jamie, shall I leave now?
Right, sir. Thank you very much, sir. And
Okay. Have a nice day.
Yes, sir. Thank you very much, sir. And sending you a token of appreciation as well for your efforts today.
Thank you.
So to all the members, we just wanted to inform you that in the month of February, we'll be having a partnership with the Faculty of Dental Sciences, University of Peradeniya, where we would be organizing 3 workshops, hands-on workshops, one on molar endodontics, one on orthodontics, and as well as one workshop on crown and bridge preparation. We'll be announcing the dates of these workshops within the next week. So you may be able to register for those if you are interested. And we have a lecture series that will be organized on the topic of dental implants that also will be a collaboration with the dental faculty. So stay tuned. Thank you very much for joining with the lecture today and have a pleasant evening.